Good evening, everyone. Welcome to tonight's Team Peds session with NapNap. We'll give people a little bit of time to join in. If you're here and you want to comment what state you're joining in from, where your practice setting is, and what SIG you belong to, go ahead and write in the comments. I'm coming tonight from South Florida, and I'm part of the Children and Youth with Special Healthcare Needs. My name is Taryn Hamer. I'm a dual certified pediatric nurse practitioner with pediatric neurology. So once again, if you're joining us tonight for this presentation for Team Peds, brought to you by NapNap and the Children and Youth with Special Healthcare Needs SIG, go ahead and put a comment in, tell us where you're watching from. And if anyone wants to just chime in on where they're watching from tonight, what state you're a part of, where your practice setting is, inpatient, outpatient, specialty care. And we'll get started in just a little bit. We're going to be talking about the development of seizure action plans tonight in children with epilepsy. Give people about 20 more seconds to log in. Tonight, we're doing Team Peds, Children and Youth with Special Healthcare Needs, talking about seizure action plans. If you're just joining us and you want to type in where you're from, where you're watching from tonight, where your setting is, where you practice in, and if any of the healthcare SIGs that you belong to, go ahead and type in the comments. If anyone can just go ahead and give me a thumbs up or comment and let me know that if you're hearing this audio and video okay. All right. So I think we'll go ahead and probably get started pretty soon. So my name's Taryn Hamer. I'm a nurse practitioner, dual certified doctorate, prepared APRN. My current practice setting is in the outpatient pediatric neurology setting. Prior to this, I have experience as a provider in the cardiac ICU, as well as RN experience in pediatric ICU, as well as developmental behavioral pediatrics. Even prior to becoming specialized in pediatric neurology, I've cared for patients with seizures and epilepsy before, and I think that highlights the fact that you can care for patients with seizures and epilepsy pretty much anywhere. In the cardiac ICU, I had patients who would develop seizures after a sort of brain bleed on ECMO. I had patients in the PICU that would develop epilepsy after a really bad meningitis or a traumatic brain injury. And then patients in the developmental behavioral pediatric clinic who had seizures and epilepsy, who they may have had cerebral palsy or other genetic conditions that predisposed them to epilepsy. And I'll be honest, seizures used to kind of scare me. I was nervous of taking care of patients with seizures because I didn't really have a good grasp on the basics of seizures and epilepsy. And I think that's important to know, the basics of seizures and epilepsy, because they can present in any clinic, any healthcare setting, not just neurology clinics like mine. So there's a very high chance you may take care of them at some point in your career. I believe that one of the easiest ways to become more familiar with seizures and epilepsy is understanding the development and the creation of seizure action plans. If you can understand your patient's seizure action plans, it can actually tell you a lot about their diagnosis and their plan of care. So my hope is in the next 12 to 15 minutes or so, you'll not only become more familiar with the elements of a seizure action plan, you will also feel more confident in your ability to understand your patients with seizures and epilepsy, and then be able to help out in an emergency setting, should one arrive while they're in your care. So a couple core concepts I think are important just to kind of identify before we dive into seizure action plans is that not all seizures are epilepsy, but seizures have the potential to progress to epilepsy if the insult to the cerebral cortex is severe enough. Kind of the basic principle that I first learned when I was starting in neurology was basically anything that can insult the cerebral cortex can cause epilepsy. So what is epilepsy? It's basically just a state of enduring predisposition to recurrent epileptic seizures, and it may arise from a variety of causes. Certain things that cause epilepsy that are currently known. There's genetic conditions. There's currently over 30 known epilepsy syndromes that have been identified. Anatomical and structural reasons that can either be acquired or genetics. Some of these things could be tumors, strokes, traumatic brain injuries, whether prenatal or perinatal, hemorrhages, and then congenital anomalies, neurocutaneous syndromes. Inflammatory conditions can also cause epilepsy. Infection, this one's huge. Some of the most common causes of epilepsy worldwide are due to infection. And it's important to note that acute illnesses and acute infections that cause seizures typically are self-limited and they will resolve after the infection is taken care of. However, if the infection causes a severe enough brain injury, that patient can develop epilepsy. Metabolic conditions and transient metabolic states that are disturbed can also cause epilepsy. And then there's unknown. We simply don't know for some of the cases. So that's important just to kind of realize that these patients can present from everywhere. They can have multiple healthcare conditions, such that children and youth with special healthcare needs often do. So it's important to know that you could basically see a patient with epilepsy no matter what practice setting that you work in. So let's kind of dive into the elements of a seizure action plan. So the way that I create my seizure action plans for my clinic is I've used the template created by the Epilepsy Foundation. They have a really nice form that you can get online and it's really easy to understand. So that's why I've kind of based my own seizure action plans based off of the Epilepsy Foundation's guidance. So the first thing that should really be on your patient's seizure action plan is just general information about their specific seizures. So they should have some information that lets you know what are specific seizure triggers for them. Some of the most common ones are non-compliance in known epileptics, stress, any sort of fever or illness, sleep deprivation, certain drugs and alcohol, hyperventilation, and flashing lights. Those can all be triggers for seizures. Next, the seizure action plan should tell you what type of seizure, what type of epilepsy the patient has. There are many different types of epilepsy, but it's important to know some of kind of the main terms so you can kind of know what you're looking for if your patient has seizures. One thing that I really liked was the Epilepsy Foundation kind of gives some pictorial guidelines on what certain seizures can look like, and that can be really helpful for providers and healthcare professionals that maybe don't practice in a neurology setting. So your patient could have atonic, or otherwise known as drop seizures. They could have absence seizures where they stare off into space. They could have tonic, clonic, or grand mal tonic, clonic seizures, and those are the ones that usually get us into trouble and that need immediate attention. Also on the seizure action plan, there should be information about your patient's seizures and how long the duration typically lasts for them. What's a normal seizure length for them and when to give medication. It'll tell you, okay, at this point we need to give medication. So that's really important to know as well. Also the frequency. Is your patient one that has, seizure clusters, and when do we need to administer medication if it's too frequent? Another element of information should be kind of what happens to the patient during the seizures. Do they normally remain conscious, or do they lose consciousness or have altered awareness? Is there changes in their sensory perceptions, abnormal body movements? Do they fall to the ground? Autonomic things like lip smacking, blinking. So just to kind of help you know what you're looking for should they have a seizure. And this kind of lets you know, okay, is this their typical seizure, or is this something else that definitely warrants, notice to their neurology, but possibly 911 if it's too severe. And further down on your seizure action plan should have some general first aid and safety measures. So whenever someone's having a seizure, we always want to lower them to the ground, keep them away from objects that could cause them harm, turn them on their side, but do not place anything in their mouth. It'll let you know if they have a vagal nervous stimulator or a VNS, and we'll kind of discuss that in a little bit, but if there's a presence of the VNS, how do you activate it? And then it's just important to always have someone stay with the person and help reorient them after the seizure stops. I really like seizure action plans that have space on them for recording. So think, if you worked in the hospital setting, there's always a documenter for a code situation. Similar for a seizure, someone always should be recording what's happening. It's important if you have more than one person at the scene, when an epileptic patient is having a seizure, so you can have one person attend to them and then one person be recording what's happening. One person keeping them safe, one person documenting. This information could be really valuable to the patient's family, the neurologist, and then emergency medical services if they are called. A lot of seizure action plans have space to document, but the main three things to focus on are timing the seizure, the length, write down what happens to the patient during the seizure, and then write down the times of any medication given. This is really important in case emergency medical services need to be called. After that, after the first aid and the recording, there will be pretty clear-cut guidelines on what medication to give, how to give it, and when to give it. So know the routes of administration. Typically in the outpatient setting, you're either going to have rectal or intranasal. If your patient is under age 6 or they have special healthcare needs, their medication might be rectal. If they're older than age 6 with no special healthcare needs, they might have an intranasal rescue medication. The dosing varies by age, and it's not super important for you to remember the exact dosing based on their age or their weight because it comes pre-dosed anyways. So all the vials for rectal medications and the nasal sprays will already be pre-dosed and ready that anyone can administer to them. It is good to know though what you are administering. So the medications that we use for rescues are benzodiazepines. So just remember basically your ABCs, your airway, breathing, circulation. After you give a benzodiazepine, you need to be watching that patient close and just making sure that all the ABCs are in line while they come out of the seizure or while you wait for help. Another part of the seizure action plan is information on when to call 911 during status epilepticus, which is a medical emergency. So status epilepticus is an ongoing seizure greater than 5 minutes or recurrent seizures without a return to baseline and seizures that are not responsive to the rescue medications. We know that seizures that last greater than 30 minutes can be very, very dangerous to the patient. So that is why foundations, guidances, protocols have all recommended giving the rescue medication at the 5-minute mark if a seizure is still occurring. You always want to call 911 if the patient is having any difficulty breathing after or during the seizure, if there's any serious injury that occurred or suspected serious injury with the seizure, such as a seizure that occurred and caused a fall from a great height, and then any seizure in water is something that always needs to be called 911 for further evaluation. So just a little bit more on status epilepticus. It's the most common medical neurology emergency in childhood. About 10 to 20% of children with epilepsy will have at least one episode of status epilepticus. It's serious and it can be life-threatening, and it is a medical emergency. The 5-minute window kind of corresponds with the time that urgent treatment should be initiated. Treatment delay has been associated with delayed treatment response. So when in doubt, give the medication and call 911. Some of the systemic complications from status epilepticus are hypoxemia, acidemia, glucose alterations, blood pressure changes, and potentially increased intracranial pressure. Some children, unfortunately, who have prolonged or inadequately treated status epilepticus can have residual neurological sequelae from it. A couple things I want to touch on that should be included in every seizure action plan, but are a little bit less known elements, are items about drug-resistant epilepsy. So some patients have really severe epilepsy, and they are considered a drug-resistant epilepsy when they have failed to become and stay seizure-free with adequate trials of at least 2 anti-seizure medications. You might also hear it called refractory, intractable, but drug-resistant epilepsy is what we call it in our practice, and you will see that a lot in the literature. So if your patient has drug-resistant epilepsy, it should be notated on their seizure action plan. And if they have it, they may have some adjunctive therapies in addition to their anti-seizure medications that you should just be aware of. One could be the presence of a vagal nervous stimulator, or a VNS, that I mentioned previously. Basically what a VNS is just a battery-powered device similar to a cardiac pacemaker that is surgically placed around the left vagus nerve. And this device helps prevent and lessen seizures by sending regular mild pulses of electrical energy to the brain via the vagus nerve. This is used in patients that are older than age 4 with focal seizures that are refractory to anti-seizure medications. If your patient has a VNS, it should be notated on their seizure action plan. The VNS will automatically be sending signals according to its programmed settings throughout the day, all the time. But the patient will also carry a magnet with them at all times for if they are having a seizure that can be hopefully stopped with on-demand stimulation. So if your patient has a VNS, you will take the magnet and swipe it over the generator in the left chest area, and that will send an extra burst of stimulation to the brain. Some other things your patients with drug-resistant epilepsy might have, they might be on a ketogenic diet. So you may be familiar with this with other medical conditions, but basically a ketogenic diet is a high-fat, adequate protein, low-carbohydrate diet. There's still a lot of research going on ketogenic diet and epilepsy, but the general principle is that the ketogenic diet causes the body to produce ketones, and the presence of ketones may decrease seizure activity in some kids with epilepsy. And then finally, if your patient has what's considered drug-resistant epilepsy, they may well be in the workup phase for possible epilepsy surgery. So this is really important that those patients have accurate seizure logs and calendars, as this is critical in the workup planning if they are going to be a candidate for a surgical procedure for their epilepsy. So your documentation, if the seizure occurs while in your care, can be really beneficial to their epileptologist and their neurology team. Just to kind of wrap up, so like I mentioned before, I use my seizure action plans that I model from the Epilepsy Foundation. I think they have wonderful resources on their website. And if you just want to play around and kind of look at their website, it can give you a lot of information on kind of just what all is involved in a seizure action plan, what's the information you need to know for your patients that have epilepsy. They have a lot of really good resources under their epilepsy toolbox section. And like I mentioned, they have their longer versions that are a little bit more in depth with all of the information, including, what do the seizures look like, 911, when to call, first aid measures, medications, and then information about your patient's drug-resistant epilepsy if they are one of those patients. So that's going to be your most in-depth one. But they also have a really nice one that they call ASAP, or Acute Seizure Action Plan. And I apologize I don't have the printed color version, but this one is really nice. It's color coordinated with a stoplight, green, yellow, red for levels of intervention. There's pictures to make it easy for people to know what they should be looking for that patient's seizures. So these can be very helpful, and I often suggest that our patients keep one of these as well, because it can be a little bit more user-friendly per se to those who don't practice in neurology or may not be as familiar with seizures and epilepsy. So that wraps up my presentation on seizure action plans. I hope you have learned a little bit more about the elements of seizure action plans, what goes into the development of seizure action plans, and I would love to answer any sort of questions if anyone has any questions for me. We'll keep it open for just a little bit longer. If anyone has any questions, you can type it in the comment box. And I would love to chat with you about any sort of questions that you have regarding seizure action plans in pediatric patients. All right, well, if no one has any questions, we'll probably wrap up. I just wanted to thank you for joining in tonight. Thank you to NAPNAP for allowing me to present this. Shout out to my SIG, Children and Youth with Special Healthcare Needs. I look forward to meeting a lot of you at the NAPNAP conference coming up in the spring. And feel free to reach out to me via LinkedIn or email or any other platform if you have any other questions on epilepsy and seizure action plans. Thank you.